So, for treatment of localized disease T2 and NEM0, surgery has traditionally been used for the treatment of choice for patients with localized resectable and carcinoma of the esophagus, and continues to be a component of more comprehensive approach to esophageal cancer in a substantial number of patients. Failure of surgery alone is significantly alter the natural history of the esophageal cancer has resulted in a considerable and appropriate enthusiasm for multimodality therapy approaches. Shift towards the multimodal treatment is not only theoretically sound but also supported by results of the phase 3 randomized controlled trial. In recent trials, unlike their predecessors, which were statistically underpowered and often came to conflicting conclusions about the worth of preoperative therapeutic regimens like radiation, chemo, radiation, consistently demonstrate benefit of neoadjuvant therapy compared to surgery alone. And results from the clinical trial also brought into question the role of surgery in a multimodal approach for treatment of esophageal cancer, and with studies almost exclusively in squamous cell carcinoma, suggesting that absence of survival benefit for the addition of surgery after chemoradiation despite improved local disease control. Most clinicians investigator consider some form of combined modality treatment that includes surgery to be the standard of care for localized resectable esophageal cancer. So surgical resection, if we talk about, decision regarding surgical technique are routinely based on the personal bias, confirming comfort level of the surgeon and the subjective view of tumor biology, because solid evidence from scientifically designed trials have until recently been non-existent. Studies that used health services linked databases have demonstrated a statistically significant association between performance of surgery in hospital design as high volume esophagectomy institutions with lower complications and mortality. And a study from Netherlands noted a significant reduction in post-operative morbidity, decrease in length of stay, reduction in hospital mortality, and improved 2-year survival following centralized esophageal resection in a high volume units when compared to before the centralization projects was introduced. And importantly, the strength of inverse volume outcome relationship for esophagectomy had significantly increased over time, with an adjusted odds ratio of mortality in a very low volume hospitals increasing substantially compared to high volume hospitals. In a novel study evaluating the change point when the number of esophagectomies performed by a surgeon translate to improved outcome, suggests that at least 15 cases 30-day mortality decreased from 7.9 to 3.1%. Later change points ranging from 35 to 59 cases were associated with significantly reduction in 1, 3 and 5 year cause mortality. So there are conventional approaches of esophagectomy. First is transhiatal esophagectomy, in which we do laparotomy, cervical approach, peritumor two-field lymph node dissection, and block resection feasible for distal esophageal tumor and cervical anastomosis. Then there is transthoracic esophagectomy, in which there is Ivor Lewis, in which we do right thoracotomy and laparotomy, peritumor two-field lymph node dissection, and block resection with the middle distal thoracic tumor. McKeown is 3 holes, right thoracotomy, laparotomy, and cervical approach, peritumor 2-field or 3-field lymph node dissection, and block resection feasible for mid or distal thoracic tumors and cervical anastomosis. Left thoracotomy with or without cervical approach, Peritumoral lymph node dissection, intrathoracic cervical cervical anastomosis. Left thoracoabdominal is left thoracoabdominal approach. Peritumoral two-field lymph node dissection and intrathoracic anastomosis. So first we will see what is transhiatal esophagectomy.